Assalamu alaikum, everyone. I hope my voice and is clear to you, all of you. There is a little bit. Uh, Hold on. Assalamu alaikum. Uh, is my voice clear to you? Okay. Assalamu alaikum, all the participants. Okay. Is my voice clear to you guys? So that we should start our webinar. Okay. Uh, I welcome all the participants and a special welcome to Dr. Saba Rizwan, and she is live, and we are going to start the webinar. As you all know, that today our topic is a special test of shoulder joint. So we are only going to be talk about the shoulder joints, and our worthy speaker, our respected speaker is Dr. Saba Rizwan. She graduated from Dow University and currently serving as a physiotherapist at Sports and Rehab Clinic, Karachi. So we are going to welcome her first, and then all she will teach you regarding the special test of the shoulder joint, and any sort of the query that you have, you just have to put into the comment box, and we will answer you from our speaker just right at the end of the session. So now I'm going to call her. Here's Dr. Saba Rizwan. Assalamu alaikum, Dr. Saba. Assalamu alaikum, Dr. Saba.
Can you hear me?
Yeah. Is my voice is clear to you, Dr. Saba?
Yes, your voice is clear, but this disturbance here.
There's an interruption from your side.
Yeah, but I have muted my device. Hello?
Okay. Now can you hear me?
Yes, I can hear you, but okay. Is it fine?
Yeah. Your voice is also clear, ma'am. Can you show the presentation
Okay, thank you
if you
so much,
want?
Dr. Dileep, and thank you, CMT team, for inviting
Yeah.
me. It's pleasure being here. Thank you so much. Is my voice clear to you?
Yes, Dr. Sapa, your voice is clear. Now just show me the presentation if you want, so that
Yeah, I'll show
then
the
I will be the off
presentation.
the screen.
Yeah, I'll show the presentation. Okay, can you accept? I've shared the PPT.
Yeah.
Is PPT received by you, Dr. Dileep?
No, ma'am, not yet.
Not yet.
Can you highlight the name with which the device?
It's by Dr. Fahad Farooq.
Oh, okay. Yes.
I'm sharing it again.
Yes, ma'am. Got it.
All right. Okay, so can I start?
Yes, ma'am. Now I am just removing myself, making myself off the screen. Now it's over to you, Dr. Saba.
All right, thank you so much. Thank you, Dr. Dileep. All right, everyone. Assalamu alaikum and good evening to all of you, and thank you for joining the webinar. Today, the topic we are going to discuss is the special test of shoulder joint. So we will quickly go through the anatomy of shoulder joint and its biomechanics because it's individually it's a little complex. Through this, I hope all of you at this stage knows the anatomy basic of shoulder joint and its functions. So we will quickly go through. Here we have a complex shoulder joint. As you can see in the PPT, we have 5 articulations. We have a glenohumeral joint, we have sternoclavicular joint, acromioclavicular joint,
Sorry,
coracoclavicular joint,
sorry to
and
interrupt you,
scapulothoracic joint.
Dr. Saba. There's a echo
Sorry?
issue from your side. The voice is getting double and double again and again.
Sorry, Dr.
So
Dileep, I cannot hear you.
make sure that your mic is muted from another device. Only the
My mic
presentation
is
is
mute.
sharing.
My mic is mute. Hello?
डॉक्टर साहब प्रेजेंटेशन आपकी शो नहीं हो रही आवाज जो है वो आपकी डबल हो रही है मैं रिमूव करता हूँ दोनों एप्लीकेशन आप फिर से मुझे रुके सेंड करें ठीक है डॉक्टर साहब
All right, all right.
sorry for the interruption guys there is a technical issue and soon Dr. Sabha is going to join us and we are going to start the webinar again.
Hello?
Yes Dr. Sabha आप क्लियर हैं आप जो है वो प्रेजेंटेशन के लिए रिक्वेस्ट भेजें
प्रेजेंटेशन के लिए रिक्वेस्ट जी मैं भेजती हूँ एक सेकेंड I don't know where it went and sir is outside. He has this. I need to join it through the link you've sent, na?
yes you have to click from another device on the same link.
Yeah, but I don't have the link in this device. It was in WhatsApp.
Yes.
Can you just wait a bit? तब तक I can just talk up here. हम start कर देते हैं PPT.
Yeah, sure, Dr. Sabha, it's over to you.
Yeah, because the participant won't waste their time. Na, we'll just go through the basic anatomy till then. All right. So what we have is we have 5 different articulations of shoulder joint, 5 different joints formed by 3 pectoral girdle bones. We have a glenohumeral joint, we have acromioclavicular, coracoclavicular, sternoclavicular, and scapulothoracic joint. That's why shoulder is very complex. The ball and socket joint typically is a glenohumeral joint. It provides the greater mobility to the joint. Almost every movement is performed at this joint. First, second is the sternoclavicular joint, which is formed by the sternal manubrium sterni and the proximal end of the clavicle and the acromial clavicular joint, they provides the stability to the clavicle and scapula respectively. Then we have a glenoid fossa. As soon as PPT will get back, I'll show you the picture. It has a glenoid labrum. Labrum is very important. It deepens the glenoid fossa, which is attaching your humeral head, and it provides the stability to the glenohumeral joint. Any tear or anything which happens to, or your labrum is injured, eventually your joint won't have its stability, and it will lose its stability. Then coming to the bones of pectoral girdles, we have three bones: clavicle, scapula, and humerus, where clavicle is positioned just superior to the first rib, and it's attached to acromion and coracoid of scapula, forming acromioclavicular and coracoacromial joints. Where just wait, so we can start the PPT. Sir, the link is gone. Can we just start again, please? All right. Till then, we are moving to the scapula. Scapula is a flat bone which has multiple muscular attachments, and it's attached to the humeral with glenoid fossa, forming glenohumeral joint. Then again, we have two joints, acromioclavicular and coracoacromial. These are the basic bones and the 5 joints which are formed by the shoulder joint. Now moving on to the muscles, we have numerous muscles encircling the shoulder joint, but we will discuss the major muscles which are involved in the injury or the problems or disorder we will going to discuss in special tests. So we will consider only those muscles. Here we have the most important muscle, which is known as rotator cuff, which has 4 different muscles in it. We have supraspinatus, infraspinatus, subscapularis, and teres minor, which have different functions of their own, and they collectively provides the stability to your shoulder joint because it's attaching to the proximal humerus. Where we have this infraspinatus and teres minor are the external rotators of your shoulder, and subscapularis is the medial rotator of the shoulder. Okay. So Dr. Dileep, is the PPT is showing to you now? Is PPT visible? Okay, here it is. Here is that glenoid labrum, which is encircling your glenoid fossa and giving the stability to the joint. Coming on to the bones, here we have this clavicle attached to the acromion and coracoid process of scapula, forming the coracoacromial and acromioclavicular joints respectively. Here we have this humerus attached to scapula, forming glenohumeral joint, and this scapula has multiple muscular attachments. Coming on to the muscles, we have this supraspinatus. Is the main function of supraspinatus is the initiation of the abduction. Abduction of the arm done from 0 to 15 degree is done by supraspinatus, and beyond 15 degrees continued by deltoid. Then you have subscapularis, which is your medial rotator of shoulder, and infraspinatus and teres minors are the external rotators of the shoulder. Then we have a deltoid muscle, which superficially lies on the proximal humerus, and it has its 3 fibers, one coming from the body of the clavicle, other is from the spine of the scapula, and the third one is from the acromion. And the function depends upon which muscle fibers are activated. Then we have a bicep brachii muscle, which is commonly known as our bicep muscle. It's also lies on the top humeral bone, and its function is to supinate the forearm and flex the elbow. Last muscle we are here discussing is latissimus dorsi, which is basically the large muscle of a back, but it attaches on the humerus, and its function is to move humerus from away and closer to the body. Okay. Here we will discuss the three important ligaments. We have many ligaments, but the three important ligaments which are discussed in further disorders are Coracoacromial ligaments, Coraco-Humeral ligament, and the glenohumeral ligament. Okay, PPT isn't clear. It's probably because of the internet. Just PPT is not that important. It's very less things written here. We will discuss the disorders through videos, and I'll tell you more in detail. This is just the pictorial representation. We have three ligaments here. First one is our Coraco-Humeral ligament that is formed by the coracoid process of the scapula, the tubercle of the humerus. What basically it does is it prevents your joint from inferior dislocation. Okay, Coraco-Humeral ligament prevents inferior dislocation. We have glenohumeral ligament here, this blue one, which is a large ligament. It has its three fibers, superior, middle, and inferior, and it's encircling the front part of your joint. So that's why it's preventing from the interior dislocation. Third joint, we have acromioclavicular. You can also call, coracoacromial. You can also call is the most impinged ligament in the impingement injuries. Coracoacromial ligament is from the coracoid process of scapula to the acromion of scapula. And it forms here this coracoacromial arch. And this ligament is most impinged in your impingement injuries. This was the basic overview of anatomy of the shoulder and its muscles and bones and ligaments. Moving on to the biomechanics of shoulder joint. Again, the biomechanics of shoulder joint is again a very detailed topic because all five articulations, all five joints have their different osteokinematics and arthrokinematics. Here, the representation is of only for glenohumeral joint because the most mobile joint is that. I will tell you the scapulohumeral rhyme. What scapulohumeral rhyme is that when you abduct your arm to 180 degree, the initial abduction of 60 degrees is done by scapula here, and 120 degree is done by the humerus. That's why it's called 1:2 ratio and a scapulohumeral rhyme. That this 180 degree is not solely performed by humerus, but by the addition of both the bones working together. One more important thing of biomechanics of shoulder is that a biomechanics of shoulder is different from its anatomical classification. According to anatomical classification, certain joints, for instance, your sternoclavicular joint here is, according to anatomy, is a fibrocartilaginous joint, which is immovable. But according to biomechanics of shoulder joint, this joint is hinge joint. That when you put a finger on your sternoclavicular joint and you palpate it and you move your arms in abduction or in elevation, you'll feel a movement there. So then again, biomechanics of shoulder joint is different from its anatomical classification. We will quickly move through the clinical assessment. Assessing shoulder joint or any other joint is a detailed process, but we will only discuss by its look, feel, and move method. What you will do is you will just look the patient. आप उसकी symmetry check करेंगे. You will check the any signs of scars or injuries or atrophy or any other problem which you can see just by looking. Plus, you can see any skin conditions there because certain autoimmune skin conditions are associated with joint disorders. So you have to rule out those conditions. First, second, by feel, what you will feel is you will feel and you will feel the all the bony landmarks. You will feel the AC joint, you will feel the spine of scapula, acromioclavicular joint, and coracoclavicular joint. You will check any point of tenderness or trigger points there. You will check the temperature changes in the tissue and the and anything you can check by feeling, just you will check. Then you will move. What you will move is you will perform the active and passive range of motions of all the joints of in every plane. In every plane, you will check the active and passive ranges of motion. You will check the end field. By feeling it, you will check the end field because shoulder has its firm end field in every movement. But if you feel any other end field rather than the normal, either it's empty, it's hard, it's soft, then it's abnormal. So you have to check and report. Other what you will move, you will check the muscle testing. You'll do the muscle testing through MMT. After that, what you will going to do is now you will ask your major complaint of the patient and you will perform the special test on them to diagnose or to differential diagnose what actually the problem is. There are like 150 plus tests. Here is the one of the assessment form for shoulder. You can assess it thoroughly. It's a detailed, good form. You can just assess your patient through this form. Now coming on to the special test. We have many different kinds of disorders, neurological, orthopedic, musculoskeletal, but today we will only discuss the major ones. I have characterized it according to most commonly impingement syndromes, which are collectively called as subacromial pain syndromes. So I have like 4 tests in impingement. They all have their different specificity and sensitivity, which depends on how specific a test can be and how sensitive a test can be. So specificity can be defined as आप जिस भी muscle को या जिस ligament को या जिस भी चीज को test कर रहे हैं वो test कितना percent उसी चीज के लिए specific है. The more the percentage, the more specificity of the test will be. Okay. Yes, you can write all your questions down and I will answer them in the last. All right. And the sensitivity is that how much the precise that result is giving. जितना अगर for instance आप subscapularis के लिए कोई test कर रहे हैं और जितना percentage है, if it's like 70% specific, उसका मतलब कि वो 70% subscapularis muscle ही बताएगा, not any other muscle incorporating. फिर आपने उसकी sensitivity check करनी है कि कितना ज़्यादा percent test sensitive है, यानी कितना precise result है. All these tests have different clinical values. आप किसी एक पर भी rely नहीं करेंगे. If you having positive test or positive symptoms in any one of this shoulder impingement test, you will confirm it by second and third test just to confirm. Okay, talking about impingement हमारे पास 3 जगहों पर हो सकती है according to Neers. Neers says कि हमारे पास tendinous portion of any rotator cuff can be impinged. Okay, rotator cuff can be impinged. Your Coraco-Acromial ligament. When we were discussing the ligament, I told you this is the most impinged ligament. This ligament can be impinged, and the anterior third part of the acromion. Anterior third of acromion के आगे जो tissues आ रहे हैं, वो impinge हो सकते हैं. ठीक है. Moving to the first test, which is painful arc syndrome, and what we have is इसको हम सबको कहते हैं subacromial impingement. ठीक है. This test is basically done for supraspinatus and coracoacromial ligament अगर हमें check करना है. We'll play a video here. Okay. Video play. Dr. Dileep, can you accept this screen sharing of video? I've shared the screen. Okay. What is the sensitivity of this test is 53% and specificity of this test is 76%. What happens is कि जब हम अपना arm abduct करते हैं तो हमारा glenohumeral joint नीचे glide करता है और अगर कोई inflammation present होगी या कोई चीज़ impinge हो रही होगी तो वो gliding perfect नहीं होगी और वो impinge करेगी किसी भी tissue को जो उसके बीच में आ रहा है. Acromion के नीचे जो भी चीज़ आ रही है वो उसको impinge करेगी. Either it can be your supraspinatus muscle or either it can be your Coraco-Acromial ligament. What you will do is how we will perform this test. Okay, I'll show you how we will perform. You will ask your patient to slowly, okay. Now look, what you will do is you will ask your patient to slowly abduct the arm till 180 degree. All right, the patient's complaining of pain. Now, if the patient's having the pain in this 60 to 120 degree of abduction, that means it has a subacromial pain syndrome. Yani either the supraspinatus is impinging or the coracoacromial ligament is being impinged. He will be feeling no pain in the initial movement, but he will feel the pain in 60 to 120 degree. Then again, his movement will be pain-free throughout. And if the patient is feeling the pain at this end range of 170 to 180 degrees, then you don't have a subacromial pain, but now your acromioclavicular joint is involved. So if your patient complains no pain in any of the range, but at the end of 170 to 180, that means you have a acromioclavicular joint issue, not the impingement of subacromial process. All right. This test is positive if your patient complains pain of 160 to 120 degree. Okay, now if you get pain in this, okay, you have an idea of an impingement. Now you have to confirm the impingement, okay, that either it's of supraspinatus or it's of ligament. You will move to another test. What we'll do is we'll go to the Neer's test. Neer, the one is the one who gives the idea of impingement in late early 80s. Okay, we will share the another test here. Okay. Why is it taking the time? Okay. Okay. By then, I'll tell you the specificity and the sensitivity of Neer's test. Neer has a specificity of 60% and a sensitivity of 59 to 72%. What happens in Neer's test is you have your patient in sitting position. Do it again.
First play the video, then share.
Okay. Yeah, I played the video and no, it's not coming. Okay. What Neer basically, Neer's test gives, if the Neer test is positive, then you have a supraspinatus muscle का overuse injury or sometimes bicep. अब painful arc से आपको पता चल गया कि या तो supraspinatus impinge हो सकता है या coracoacromial. अब आप आ गए Neer's पर. You've quickly performed Neer test. All these tests will hardly cause you a minute or less. So आपने 3-4 टेस्ट जल्दी से परफॉर्म किए 2-3 minutes में and you will get an idea कि either which tissue is impinged or which ligament is impinged. What happens in Neer's test is Neer gives the positive sign of supraspinatus and sometimes bicep. Neer's करने के बाद you will get confused कि okay bicep है या supraspinatus है. So you will quickly jump to the third test, which is Hawkins-Kennedy. First, I'll show you the video of Neer's test, and then we will move forward. Okay, it is starting. Yeah, it's done. Okay, what happens in NIRS test is you will have your patient in sitting position. You will stand behind the patient. You will stabilize scapula with the one hand, and then you will take your other hand and you will move the passive maximum shoulder flexion. You'll do the maximum passive shoulder flexion with your one hand supporting at the scapula behind, and with the other hand you will perform this shoulder flexion. Okay, let all tests play in a round. But this is the fourth one. Okay, you will stabilize one hand with scapula. You'll take your other hand. You'll do the passive shoulder flexion. If the patient complains or of its pain or the reproduction of its symptoms at the end ranges of the maximum flexion, then the test is positive. Then you can say, okay, either it's supraspinatus or sometimes it is bicep involved. Now, to confirm that either it's supraspinatus tendinosis, what you will do is you will perform the Hawkins-Kinney test. Hawkins-Kinney test is the third test. Hawkins-Kinney test has the specificity of 56 to 67%, whereas the sensitivity of 58 to 80%. This test is considered positive in case of the reproduction of the symptoms, and this test is solely for supraspinatus, but also it can tell you the bursitis. Bursitis of shoulder is by two tests. Painful arc, the first test we performed, and this third test also can tell you the bursitis. Is the video played? Yeah. Okay. Here we have a Hawkins-Kinney test. What you'll do is you'll have your patient in sitting position. Then you will have that affected arm 90° of shoulder flexion, then 90° of elbow flexion. When the patient's having the pain in supraspinatus, now after only maintaining this position, they'll start having the pain. What you will do is you will take your one hand, you will stabilize the scapula properly, and with the other hand, you will put a internal glenohumeral rotation. You will perform a glenohumeral rotation with your other hand. The patient will complain of severe pain at the supraspinatus tendon. That confirms that it has a supraspinatus tendinosis. All right. This is how you perform a Hawkins-Kinney test. All right. You've done the painful arc syndrome. Okay, you've got the idea of impingement. You've confirmed it with the NIRS test. You got the idea of supraspinatus and bicep. You got mixed. You jumped to Hawkins-Kinney and you confirmed that, okay, either a supraspinatus tendinosis. Now I will manage that. But the last test, which is the full Ken test for shoulder impingement, it has a very high clinical value. It tests integrates the supraspinatus tendon tear. Now it will, full Ken test is very important. You have to have your full Ken test done if you have to confirm the shoulder impingement. Come with sequence wise. All right. What you will do is full Ken test for rotator cuff lesions. It has the specificity of 50% and sensitivity of 70%. What you will do is you will have your patients both the shoulders flex at 90° in scapular plane, which is also known as scaption. All right. Then you will apply the downward pressure and ask your patient to resist that movement. Try to apply the pressure on the forearms rather than shoulder. Patient is unable to resist the movement and it will start complain of pain. Then it's the positive sign for impingement. We also have one other test, which is empty Ken test or Job's test, which is for supraspinatus. If someone's empty Ken test is positive और उसका full Ken test negative आया है, तो फिर इसका मतलब कि आपका जो impingement है वो rotator cuff पर नहीं है. That's some other reason for that. Your full Ken test has to be positive in order to diagnose of an impingement syndrome. Quick review, here you have 4 impingement tests. Pain arc syndrome, which will deal with supraspinatus muscle and your Coraco-Acromial ligament. Then you have NIRS, which will test the supraspinatus and sometimes bicep. You have Hawkins-Kennedy that will tell the supraspinatus tendinosis, and you can test full integrity of supraspinatus tier by full Gait test. Now, what we have is we have a labral tears. Labral tears are the tears of the glenoid labrum, which is encircling your glenoid fossa. That glenoid fossa, any tear to that. Okay. Lateral tears हमारे पास दो टेस्ट से टेस्ट होते हैं, Yergazin से and O'Brien active compression से. Yergazin test is also for slap lesion. Slap is SLAP, superior labrum interior and posterior. Your labrum which is encircling your glenoid fossa, वो दोनों दो जगह से tear हो सकता है, या तो interior part से या posterior part से superiorly. ठीक है. We have this Yergazin test. Yergazin's test was primarily designed to test the transverse humeral ligament. All right. This test can be done to either check the bicep pathology or the slap lesion. ठीक है. For bicep pathology, it has the specificity for 88% and sensitivity of 32%. This test is mainly done for bicep pathology. And for slap lesion, it has 12% sensitive and 87% specific. What you will do in your Yergazin test is you will have your patient in sitting position. You sit in front of your patient. You have the elbow flex at 90 degrees in full pronation and stabilize against the patient's own body. You will keep your one hand on the bicipital groove to feel the bicep tendon. You will ask your patient to supinate his forearm while you resist the movement. And at the same time, you have to keep your hand on a bicipital groove and feel the tendon. If during the resistance of supination you feel a pop out of bicep tendon from the bicipital groove, that means your test is positive for bicep pathology. Your patient is having a bicep pathology. But if you don't feel the tendon popping out and the patient complains of tenderness or pain without the tendon popping out, then you can suspect, okay, either it's a slap lesion, your labrum is teared. But it's more specific for bicep pathology. Now, if you have without popping out pain, you will confirm your labral tear by the active O'Brien test, which is solely for labrum. And then you can confirm that it's a labral tear and you have to manage it accordingly. All right. Glenoid labrum test or O'Brien test, also known as active compression test, has the sensitivity of 67% and specificity of 37%. Okay, this is the O'Brien test. What you will do in O'Brien test is it's similar to Speed's test. We'll further discuss Speed's test. It's for bicep. You have in standing your patient shoulder flex to 90 degree. All right. Then you bring it into 10 degree of adduction, and then you ask to internally rotate the shoulder. Okay, you have to maintain this position and apply the downward pressure and ask your patient to resist the movement. One thing, shoulder 90 degree flex, 10 degree adduction, internally rotation, applying the downward pressure. Try to apply the pressure more on the forearms rather than on this part. You have to do this, then you have to change the position. You have to supinate the arms, just palm facing upwards, externally rotate the shoulders, and now apply the pressure again and ask the patient to resist this movement. This test will be positive when your patient complains of pain in the first position when you had in adduction and internal rotation, and the problem or the symptoms disappears or it lessens in the second position where the palms are facing the ceiling. The test is positive. You have a glenoid labrum tear, then you have to manage it accordingly. These are the two tests for labral tears. What? Yergazins, mainly for bicep pathology with the tendon popping out. But if the tendon is not popping out and the patient is complaining of pain, You will go for an O'Brien test, you confirm it, your laboratory, and you manage it accordingly. Now we have 4 different tests which aren't categorized as impingement, but they are for different muscles specifically. We have the bicep test or the speeds test for bicep pathology. It has the sensitivity of 20% and specificity of 78%. Just to check bicep. You can also correlate it in that way that if your Gaisens were positive with a tendon popping out, you can double check it with the speeds test. What you will do is you will ask your patient to extend the elbow, fully supinate the forearm, and then bring your shoulder to 90 degree of flexion. All right, extending the elbow, supinating it, and bringing it to the 90 degree of flexion. In this position, patient is asked to resist the downward pressure. Because in this position, your bicep tendon is acting like a suspensor cable. If there's any inflammation present now, he won't be able to maintain the position and you will have a pain in the bicipital groove. This is speeds test just for bicep. You can only check bicep with the speeds test. Coming on to the test we've discussed before, your empty can test or Job's test. This is for indicates it is a very high clinical value. It's for supraspinatus muscle or scapular nerve. What you will do is you will have your patient in standing position, arms in 90 degree in scapular plane and thumb pointing downwards, like you're emptying a can. Your thumbs should point downward and your shoulders should be in 90 degree of flexion in your scapular plane. You will apply the downward pressure and ask the patient to resist. A positive test is indicated if the patient feels weakness or pain in the affected arm rather than unaffected arm. If your empty can test is positive, and so you have to check it by your full can test. But if full can test comes negative, that means your impingement is not from rotator cuff, it's either any other lesion. Because empty can test is also telling you if there is a neuropathy of scapular nerve. So this is how you can do. We have our second last test of drop arm sign, which will solely tell you about the supraspinatus tear. Not impingement, but only the supraspinatus got teared is being recognized by drop arm test, which is a high clinical value because it's sensitive 73% and specific is of 77%. This diagnoses the full thickness tear of supraspinatus and infraspinatus tendon. What you will do is you will have your patient in standing or sitting position. You'll bring the affected arm to 90 degree of abduction and you'll externally rotate it passively like this. You will support this hand and then you will slowly remove your hands and you will ask your patient to slowly bring his hand down. The person with supraspinatus tear won't be able to maintain this position or won't be able to bring it slowly. So your test would be positive for supraspinatus tear. Okay, lastly we have is how to differentiate true frozen shoulder from pseudo frozen shoulder. Share this video.
Share.
Okay, what's frozen shoulder? It's the most common, disorder we encounter on a daily basis, and everyone's writing every shoulder pain as frozen shoulder, which is not true. You have seen there are so many different muscles and impingements can be causing the shoulder pain. Adhesive capsulitis is a very common disorder. We have to distinguish that either it's pseudo or it's true. Pseudo frozen shoulder can be through immobility, or a frozen shoulder can be through for many causes, immobility or thoracic outlet syndrome or any other thing. But what happen is you have to check either it's a true frozen shoulder or it's pseudo frozen shoulder. So for checking this, the video we're going to start anytime soon. Till then, I'll tell you that coracoid pain test. Coracoid pain test is a test that is done to assess true or pseudo frozen shoulder. It has a sensitivity of 96% and specificity of 87 and 89%. To distinguish between pseudo or frozen shoulder, what you will do is you will palpate 3 points. You will palpate the AC joint, you will palpate the acromioclavicular triangle, and you will palpate the coracoid process. Okay, you have to palpate these 3 points from your fingers, and you have to record the pain severity on VAS scale. ठीक है, palpate the AC joint, palpate the acromioclavicular triangle, which is interior and lateral to the acromion, and palpate the coracoid process with your first digit. As soon as you palpate the coracoid process, your patient will jump from the pain. You have to record the pain in VAS scale, and the test is considered positive अगर उसको सबसे ज़्यादा पेन coracoid process में होगा. उसके बाद उसको acromioclavicular triangle में second number पर ज़्यादा पेन होगा, और third part is the AC joint. Your test is positive. And if you have the ultrasound of shoulder joint, you can check that these 3 points will be inflamed. And if you can ask कि हम इन कौन सा special test कर सकते हैं shoulder joint के लिए, adhesive capsulitis के लिए, तो वो है Epley's scratch test in 3 maneuvers. You have to check either they can bring their hands through the back of the other shoulder, or they can bring here, or they can bring back. So all movements are checked: external rotations, abductions, extensions, and medial rotations being checked by this position. Flexion and adductions being checked by this position, and Epley's scratch test, the external rotation and the abduction is checked by this position. Epley's scratch test is the special test for frozen shoulder, and the coracoid pain test is the test which distinguish true and pseudo frozen shoulder. ठीक है, जब भी कोई patient आए and they complain of frozen shoulder, you have to just palpate these 3 points and you can get the idea that either they have the true or frozen shoulder or not. First thing, there is some technical issue. The last video will be played probably at the end. All right. I will start the video of that coracoid pain test. And that's all. These are all the 10 tests we had to discuss. There are numerous, but according to time and the digestion of a person as well, this is enough in 1 hour that you have 4 impingements. Again, a quick review: you have a painful arc syndrome, you have a Neer's test, you have Hawkins Canadian, your full Kent test. Then for labrals, you have your Gazin and a active compression test. Then you have other tests, speech test for bicep pathology. You have drop arm to tell you the supraspinatus tear. Then you have a empty Kent test also for subscapular nerve and your supraspinatus. And you have lastly the true and frozen shoulder. The video will be played. Okay.
Last video is not playing because it's only
Can I play this from this device?
If it is on that,
It is.
then share.
But I don't have the option to share the screen.
Hello.
Hello?
Yes. Would you? I'm not getting any sort of request from your side.
Yeah, I know. It's my laptop got off or for a time लगेगा. The last video is not playing. By the time, can we answer the questions if we have any?
Okay. Yeah. Sure. But kindly mute your mics. And from another device, I am removing it basically.
The other devices mics are mute. Only my mic is on. You want me to mute that as well?
Dr. Sabha, there is still interruption from your side. Can you mute the mic? Yes. Okay. Can you hear me, Dr. Sabha?
I can hear you.
Yeah. I have just muted you, remaining your device that the presentation was showing on and the videos were playing, and it's time, I hope, to answer the questions. Then we will wind up the webinar.
Yeah.
First of all,
All right. Because
no doubt
by
it
the
was
time
very informative and fantastic webinar it has been. And let's
thank
have
you
a
so
look
much.
to the questions for you. And secondly, I request all the participants, kindly don't ask the questions privately to me. Basically, you have to ask the question in comment box. Okay, Dr. Sabha, can you hear me? So that I should display
Yeah,
the
yeah.
questions.
I can hear you. I can hear
Okay,
you. Just
here at the end of your display, the questions will be shown.
okay.
What is the atrophy? The question is from
Okay.
Nimra Mehman.
Atrophy is basically the muscle wasting. Your normal muscle bulk is reduced to very thin muscles, and either can be due to immobility or no movement. जब आपका मसल वेस्ट हो जाएगा और एक बंदा लीन और आपको फील करेगा कि ओके इसका आप कंपेयर करेंगे दोनों लिम्स को एंड यू विल चेक कि एक लिम्ब में मसल ठीक है और अदर लिम्ब में मसल नहीं है ड्यू टू एनी फ्रैक्चर के बाद रिड्यूस मसल बल्क है डिनर्वेशन हो गई है प्रोलॉन्ग इमोबिलाइजेशन है आपका मसल बल्क रिड्यूस हो जाएगा दैट्स नोन एज एट्रोफी
Okay, and what is sensitivity?
ओके सेंसिटिविटी है कि आपका एबिलिटी ऑफ टेस्ट टू करेक्टली आइडेंटिफाई द डिजीज वो टेस्ट कितना करेक्टली आइडेंटिफाई करेगा उस डिजीज को ट्रू पॉजिटिव वो सेंसिटिविटी है और कितना विदाउट द डिजीज है ट्रू नेगेटिव दैट्स द स्पेसिफिसिटी ऑफ अ टेस्ट
Okay, I hope Said Kashan Heather is clear your question.
okay
What is difference between Dr. Sabha impingement and compression test?
sorry
Between difference between impingement and compression.
Okay, impingement can be occur in only these three portions I have mentioned, and its impingement only occurs below the acromion when your shoulder moves in elevation. So these structures can be impinged between the acromion and the humeral head. So they gives the pain symptoms like numbness and severe sharp shooting pain. But compression either can be occur at nerve roots, and there are different tests for compressions which will be in probably sometime other in other session.
Okay, Dr. Sabha, the special test that we perform, whatever we have learned today, are these valid or applicable for the true or
Yes, yes.
pseudo frozen shoulder?
Yes, it's very much high clinical value, especially the coracoid pain test. I'm sorry the video is unable to play, but that coracoid pain test is very specific with high clinical value to distinguish between true and pseudo frozen shoulder. You have to palpate these three bony landmarks like AC joint, coracoid process, and acromion triangle, and record the pain in the VAS scale, or you just ask the patient how they feel. They will jump from the pain when you palpate the coracoid process, suggesting that these are a true frozen shoulder. And the special test you can perform for frozen shoulder is Epley's scratch test. I've told you the three maneuvers to perform these Epley's scratch test that will confirm the diagnosis of adhesive capsulitis.
So can we perform these tests on both, or firstly we have to assess either whether it is a pseudo or a true?
Frozen shoulder contains different
Frozen
disorders
shoulder contain different disorders. ठीक
which
है?
are tested by a special test.
Every special test and every disorder is confirmed by different special tests. Frozen shoulder is a very vast term because your capsule is stiff, you have your active passive ranges limited, you have your capsular pattern limitation. So it's just this coracoid pain test just tell you ki, okay, this is truly frozen shoulder and not the immobility or not the stiffness by any other reason.
Okay. Lastly, Dr. Sabha, instability and dislocation. How we can differentiate between them?
Instability and dislocation. Okay,
Instability is looseness.
instability may you will feel a looseness, your whole shoulder won't be dislocated, you will be able to move but it's unstable, you will feel the pain and you have a muscle imbalance and a ligament loosen up, you have the instability. But in dislocation you won't be able to move your shoulder, you have a severe pain, you have to relocate your joint again and then to continue your movements.
Okay. Actually, Dr. Sabha, these questions were, I know out of the webinar topic, but they are asked from the participant
No,
actually.
no, all right, no issue.
Last question from, he is from Bengali, I think. What is reverse scapulohumeral rhythm?
Reverse scapulohumeral rhyme.
Yes.
Normal
ऐसा
scapulohumeral rhyme
ऐसा
is
कोई
that
वर्ड
1:1.
यूज हुआ था?
नहीं, it was normal scapular rhyme.
Okay.
Scapulohumeral rhyme is the biomechanics of shoulder joint कि जब हम आप अपना arm elevate करेंगे ना पूरा 180 डिग्री तक, तब वो पूरा humerus में move नहीं होता. It's 1:2 ratio of scapula and humerus. Initial 60 degree of abduction is done by scapula. Scapula move करता है आपका और फिर 120 डिग्री आपका humerus move करता है, तो इसको पूरा scapulohumeral rhyme कहते हैं. जो 1:2 रेशियो है, ये बायोमेकेनिक्स है शोल्डर जॉइंट की.
Okay. It means there is no reverse scapulo, only the scapulohumeral rhythm.
सॉरी,
The
मुझे आपकी आवाज नहीं आ रही.
Okay. I mean to say, Dr. Sabha, कि reverse scapulohumeral rhythm नहीं होता.
आप अपना माइक बंद करके फिर खोलें. इट्स डॉक्टर दिलीप, इट्स वेरी डिस्टॉर्शन देयर.
Okay. Okay. Can you hear me, Dr. Sabha?
यस.
Yes. It मतलब उनका जो क्वेश्चन था कि रिवर्स स्केपुलर रिदम, तो इस तरह की कोई चीज नहीं होती. We only
नहीं,
have a
ऐसा कुछ नहीं होता.
scapulohumeral rhythm.
रिवर्स स्कैपुलर रिदम कुछ नहीं होता. इट्स जस्ट द स्कैपुलोह्यूमरल राइम एंड योर शोल्डर मूव्स इन दैट प्लेन. Initial from 60 degree from scapula and 120 from shoulder.
Okay. Thank you, Dr. Sabha. Now the last question is on your screen, and this is probably last.
As you said, coracoid pain test is for both true and pseudo frozen shoulder. We palpate coracoid process in true and pseudo, so there is any difference pain intensity. No, this coracoid pain test tells you that it's true frozen shoulder. Pseudo में नहीं होगा इस पे pain. True frozen shoulder में ही आपको coracoid pain intensity बहुत ज़्यादा मिलेगी as compared to the acromion triangle and AC joint. सूडो में आपको ये टेस्ट पॉजिटिव नहीं मिलेगा, तभी तो आप डिस्टिंग्विश करेंगे कि ये ट्रू फ्रोजन शोल्डर है और ये सूडो फ्रोजन शोल्डर है. दिस कोराकोइड पेन विल ओनली बी फेल्ट इन ट्रू फ्रोजन शोल्डर.
Okay. Thank you so much, Dr. Sabha. All the questions are
Thank
very well answered, and no doubt the
thank
webinar was very
thank you
informative
so
and
much.
wonderful. So
Thank you.
now we are
Thank
just
you for
waiting
having me.
for your last words regarding the association, and then we will invite the organizer who basically
Thank you.
made the flyer and did all the sharing and all. Dr. Javer and Dr. Shoaib Mansoor.
All right. Are they joining? Okay. Okay. I need to thank Dr. Javeria and sorry, what's the name of the other doctor who put his effort on?
Dr. Javedi and all the CMT team,
Uh, Hold on.
Okay, I would like to thank Dr. Javeria and all the team of CMT for putting an effort for this webinar, and thank you. It's been pleasure.
thank you for inviting me.
Thank you
Thanks
for
from
inviting.
CMT, and thank you for your
Thank
time, Dr. Sabha, for joining us
thank
and sharing your knowledge with us. And
thank you so
inshallah, we definitely we will do future webinars with you on another different topic.
much.
Great
Inshallah, inshallah,
session
I
it
will.
has
Thank
been.
you so much for that. All right.
Uh, thank you all the viewers for joining us. And now I would like to call the organizers for this webinar, Dr. Javeria from Isra chapter Karachi and Dr. Shoaib Mansoor from Larkana chapter. Assalamu alaikum, Dr. Shoaib
Walaikum
and Dr.
salam.
Javeria.
Yes, sir.
Can you hear me, Dr. Shoaib?
Yes, sir. Walaikum salam. My voice is clear.
Okay. Guys, these are the organizers who basically organize this webinar in such pandemic situation to share the knowledge with you guys. So it's over to you, Dr. Shoaib. If you wanted to say, then you can share your knowledge and Dr. Javera and all the participants for the certification on for the presentation. This special test of the shoulder will be provided by the Dr. Shoaib and Dr. Javera to you.
Assalamu alaikum to my all participants, and no doubt it is a very informative session on that was held today on the special test of shoulder. And thanks to Dr. Saba Rizwan जिन्होंने अपना इतना में टाइम दिया, जिन्होंने अपने पार्टिसिपेशन दी, और थैंक्स टू उन पार्टिसिपेंट्स को जिन्होंने ग्रुप ज्वाइन किया. और अगर आपका साथ रहा तो हम आगे भी आपके लिए ऐसे ही वेबिनार्स कंडक्ट करते रहेंगे. And thanks to Dr. Dileep for joining us in CMT. And it's over to Dr. Javeria for the last lines of the CMT.
Thank you so much, sir. Thank you so much, sir, Saeed and Madam Sabha and Dr. Shub. ने जो ये सारे मतलब बारिश ने हेल्प की और सारा बहुत शुक्रिया ने मेरे यहाँ किया और सारे पार्टिसिपेंट्स का बहुत थैंक यू. और प्लीज आप जो है वो सेम की लाइक करें, शेयर करें और हमारे साथ रहें ताकि आपको मोर अपडेट्स मिलते हैं और सीखने को चला. Thank you, sir, for my for arranging this.
Thank you, Dr. Javera and Dr. Shoaib. Unfortunately, due to technical issue, we couldn't hear properly to Dr. Javera, but no doubt they managed it very well. And again, I would like to thank all the participants and Dr. Saba Rizwan especially as a speaker. And in future, we will continue to organize such webinars on different topics. So keep watching CMT. Stay home, stay safe. Goodbye. Allah Hafiz.